Welcome back. Today we'll be going through the larynx. So the larynx is the protective sphincter of the throat, and it lies in the muscular layer, and it's continuous with the trachea. In front of it are the infrahyoid muscles and the thyroid gland, and it lies around like C4 to C6 within those spaces, and it is lined with the mucosa, which are ciliated pseudostratified cells. So the thyroid cartilage is larger in males. It's shield-shaped and is made out of hyaline cartilage, and it comes to a point. The point is more acute in males, and the size and the shape of the thyroid cartilage actually is one of the determinants of voices. So somebody with a more prominent and more acute thyroid cartilage has a deeper, more resonant voice. So the purpose of the thyroid cartilage is that it protects the vocal cords, and it has several components: the lamina, which are the sides, and then the superior and the inferior cornu, and those are like the horns. See in here, this thyroid cartilage. Here's the cricoid. Here's the trachea. So the cricoid cartilage is right below, and it wraps around in a signet ring shape, and it's taller in the back, and it has the articulations for the inferior cornu of the thyroid and the arytenoids, which are these smaller cartilages. So all the joints in the neck or in the larynx are synovial, and it allows the flexion and extension along with the actual neck movement. So the cricoid itself is attached to the trachea, and in children the anatomy is a little bit different because the lower point of the larynx is in the cricoid, and the cricoid is the narrowest part. In adults, it's not like that. Like, it's not as funnel shaped as in children. Arytenoid cartilages are fin-shaped cartilages, and this sits right on top of the cricoid. And then above that are the corniculate cartilages. The vocal process project forward, and those allow the attachment to the vocalis muscle. And it's kind of hard to see in the cadavers because they are actually quite small and not as easily distinguished. So we kind of have to use the larger structures as references. But the muscular process in the back, they project laterally for the attachment for the lateral and the posterior cricoarytenoid muscles. The corniculate cartilage gives attachment for the epiglottis folds, and those are paired. And the cuneiform cartilage lie inside the folds, and those function to strengthen the epiglottic folds. The folds, here's the arytenoid, here's the thyroid, and then here's the cricoid, and the corniculate are like all in the internal surface. You can see here. So this is a sagittal section. There it is. It's quite small. So here's the epiglottis, and it is it's like tongue shaped in the throat, and it lies right below the root of the tongue, and its purpose is to close the larynx so you don't aspirate while eating. And it's made out of an elastic cartilage, and it's attached to the back of the thyroid and the arytenoid cartilage by the epiglottic folds here. And the epiglottic folds are different from the vocal cords. Here you go. Here's the epiglottic fold. So the thyrohyoid membrane connects the thyroid to the hyoid. As you can see here, like, this is how And these ligaments are named. Here's the origin, here's the attachment. And the median thyroid is thickest in the middle, so you can see here. It's pierced by the superior laryngeal vessels and the internal laryngeal nerve. The cricotracheal ligament will connect the cricoid to the first ring of the trachea, which is pretty important. And the quadrangular membrane is covered in mucosa. The inferior margin will form the vestibular ligament, as you can see here. And the cricothyroid ligament forms the vocal ligament, and it's attached to the cricoid and the thyroid. And then the vocal cords are attached to the thyroid and the arytenoid cartilages. So the vocal ligament is right here, lies below the quadrangular membrane. And this is also like a sagittal view. So the inlet of the larynx is directed backwards and it's funnel shaped. It's bounded by the epiglottis along with the folds and the cartilages. It's different in babies because it's more it's less funnel shaped. It's open and it's higher up in the throat. So the larynx in the adults would be like from C4 to C6, but in babies it would be higher, and that is so that the babies can breastfeed and breathe at the same time. So by the time around like 2, they grow and the larynx will actually descend, or the inlet will descend, and that's when these children really should be starting to eat solid foods. So there's more structures that you should know. There's going to be the median glossoepiglottic fold and the vallicula. The vallicula right here, here's the folds. And the piriform fossa is bounded by their airy epiglottic fold, the thyroid cartilage, and the thyroid membrane. The vestibular folds have the mucous membranes, and they are above the vocal folds, and also known as the airy epiglottic fold. Actually, should have mentioned that. But these have the mucous membrane, and that secretes not mucus, but it secretes lubricating fluid to hydrate and lubricate the vocal cords, because the vocal folds are the ones that don't actually have any mucosa on them at all. So the vestibular folds are fixed, but the vocal cords are mobile, and that's how we speak. And the rima glottidis is just the opening inside the vocal folds. So first you descend into the vestibule, and then you will go into the infraglottic part. The saccules are on this lateral to everything and above the sinus. So the middle region is between the vestibular and vocal cords. And then the default of the rima glottis is going to be open, so you can breathe. And then the ventricles contain, or the sinuses, and those contain the glands that will secrete mucus and the lubricating fluid. And then the saccules are diverticulum of the mucous membrane that ascends from the sinus. So the muscles. Extrinsic muscles are going to be, attached to the hyoid. We covered that last semester. They really work during swallowing and speaking. Elevation is controlled by the suprahyoid muscles, and then depression are going to be the infrahyoid muscles. And the intrinsic muscles of the larynx will control sound production, and those are innervated by the recurrent laryngeal nerve. So the intrinsic muscles, the oblique arytenoid that will narrow the inlet by bringing the airy epiglottic folds together. The transverse will close the posterior part of the rima glottis, and that will allow us to whisper. The posterior cricoarytenoid muscles right here, and that abducts the vocal cords by rotating the arytenoid cartilage. The thyroarytenoid or the vocalis muscle will relax the vocal cords, and the lateral cricoarytenoid muscle will adduct and pull the vocal cords backwards. And all of these are innervated by the inferior laryngeal nerves. So these are very small but very precise muscles. The cricothyroid muscle will tense the vocal cord, and this is the only one that's not innervated by the inferior laryngeal nerve. This is the only one that's going to be innervated by the superior laryngeal nerve. The thyroepiglottic muscles widens the inlet instead, and when you breathe, the vocal cords will abduct, so pull away, and then when you speak, they will adduct. So breathing normally, the glottis is going to be triangular. Deep inspiration, like when you take a deep breath, it's going to be more of a diamond shape. There's going to be two sphincters. There's going to be one at the inlet of the larynx and then one at the rima glottis. The inlet sphincter is used only during swallowing, and the rima glottis is used in coughing and sneezing. The tongue will depress the epiglottis and allow intermittent releases of air. When you whisper, like I said before, the vocal cords are partly adducted, but the arytenoid part is open. Air is released, but only in the back, and it makes the voice sound breathy. So in the Heimlich or the Valsalva maneuver, well, we call it now because Heimlich lost his medical license, that's when you force the expiration against the closed glottis, initiating the cough reflex to clear out whatever has been stuck in the esophagus or the larynx. So the upper half of the larynx is supplied by the superior laryngeal branch of the superior thyroid artery, and the lower is going to be supplied by the inferior laryngeal branch of the inferior thyroid artery. And then the veins and the lymph, they follow those and drain into the internal jugular vein. Sensory innervation above the vocal cords is going to be innervated by the laryngeal branch of the superior laryngeal nerve, and then below is going to be the inferior laryngeal nerve. The motor innervation of all the intrinsic laryngeal muscles is inferior laryngeal nerve, like I said before, except for the cricothyroid. So unilateral complete section of the recurrent laryngeal nerve will not affect the speech too badly. There's not going to be any issues in breathing. Bilateral but complete section of the recurrent nerve will lead to breathing and loss of voice. A unilateral or partial section of the recurrent laryngeal nerve, where the abductor is going to be more affected than the adductor, so you can say it's unilateral. Affected vocal cords will assume the adducted midline, so it's stuck here. The voice is going to be breathy and quiet. As you can see here, there's going to be like a right-sided paralysis. And then a bilateral partial section of the recurrent laryngeal nerve will cause stridor, which is kind of forced speaking. If you've ever heard somebody who's not trained in, and not trained to be a singer, not trained to be an actor, and then all of a sudden you hear them on stage and you hear them forcing the words out to be loud, that's what stridor is. So the superior laryngeal nerve lesions at the vagus nerve above the pharyngeal branch will affect both the superior and the recurrent laryngeal nerve. Of course, the bilateral lesions are going to be more serious. The external laryngeal section, that's going to result in a paralyzed cricothyroid, so there's not going to be any vocal cord tension Complete sections of the superior laryngeal nerve have little symptoms or mildly hoarse voice with loss of pitch control. That means like both sides are going to be affected, so the voice is going to be quieter. Damage to the internal laryngeal nerve loss is going to be like a loss of mechanoreceptors and proprioceptive sensation, like down into the throat. Complete palsy is usually on the left side because it's longer on the left than the right. The isolated paralysis of all the laryngeal nerve will occur except for the cricothyroid, which is supplied by the superior laryngeal nerve. So the complete palsy would, like, cause, it could be asymptomatic, or it can cause a hoarse, breathy voice, and this person won't be able to manipulate their pitch. Okay. So speech and sounds are made by the length of the vocal cords, which is determined by genetics, and the pressure of air that we force through our vocal cords. So the external laryngeal nerve is subject to injury during the thyroid surgery, along with any of like neck surgeries, and the inferior laryngeal nerve and the recurrent laryngeal nerve are also very subject to being damaged during the tracheostomies. Vocal nodules are pretty common, actually. Those occur due to misuse of the voice, overuse of the voice, and inhaling irritants will also do it. Reinke's edema, it usually happens only in smokers. And look at all this. Oh, look at the inflammation. This should be clear and white like this, right? But it's very inflamed, and that happens because there's no lymphatics in the vocal cord region. There's just the vocal cords. There's no mucosa on it exactly, but the inflammation happens because of the response to inhaling the toxins of the smoke, and then the body will mount an immune defense against that. So that is problematic because it can expand upwards and into the subcutaneous layer, causing the swelling of the upper part of the neck, and in some cases obstruction. Okay, cancer. Supraglottic tumors from the laryngeal surface. Those can spread into the pre-epiglottic space and affect the nerves. This is problematic because it can infiltrate the bone. And the inferior tumors will spread into the paraglottic space, and those can extend into the subglottis and infiltrate the thyroid and arytenoid cartilage, which then could also infiltrate the thyroid gland itself. So the ventricular tumors will obstruct the mucus outflow, and fixation of the vocal cord is a good sign that this tumor is in the paraglottic space. Glottic tumors spread slowly, and the voice is just chronically husky. And anterior cord tumors can spread to the Broyles ligament and escape the larynx and change the cancer from a T1, which is isolated, to T4, which is widespread. Subglottic tumors here can spread circumferentially and impair the airway. And then the laryngeal carcinoma is squamous cell carcinoma, and it's the most common throat cancer. Okay, that's it for now. Thank you for your attention, and good luck studying.